Okay, so thank you again for having me speak. I'm going to discuss obstetric venous thromboembolism, and I'm going to review the current debate on best practices for prophylaxis. So in terms of the outline of my talk, I'm going to start with a clinical vignette. I'll review epidemiology and outcomes data. I'll focus on the data from the UK because I think that's the most important. And then I'll review the primary clinical debate related to venous thromboembolism or VTE prophylaxis and discuss some next steps for research. So here's a clinical vignette. This is based on a real case. There's a patient, 30-year-old, G1, P0, 39 weeks, no significant past medical history, who had a cesarean delivery that was planned for an obstructing cervical fibroid. No other complicating factors. Patient wasn't obese. She presented early the morning of her scheduled cesarean with spontaneous rupture of membranes. And she ended up being on a stretcher in the PACU prior to her cesarean for approximately 6 hours before the case because there was a delay. During the surgery, the sequential compression devices, the SCDs, the boots, were applied. And then they were discontinued post-operative day number 1 in the morning after she got out of bed and was ambulating to the bathroom once. And she didn't ambulate again until the evening. But in the evening, when she ambulated, she developed foot and calf pain. She syncopized shortly thereafter. And then she was evaluated bedside for the causes of the event. And about 45 minutes after the evaluation, she experienced cardiac arrest. And the autopsy demonstrated a large saddle embolism. So I think with this case, the questions that immediately come up are, could anything have been done differently? Should anything have been done differently? And can risk for this scenario be meaningfully reduced? So to answer that question, to help answer it, I think it's useful to look at epidemiology from some other places. I'll review epidemiology from the United Kingdom, which I think is very important. I'll discuss a study from the Hospital Corporation of America that's been very important in dictating what our clinical practice is. And then I'll review some national data from the United States. So the UK have these maternal death reports that come out every year now, the confidential inquiries into maternal deaths, where they review clinical records of the deaths that occur in the 700,000 deliveries per year that occur in the UK. And the data is pretty good quality. They have all of the medical records. So they're able to analyze how many VTE deaths there are among pregnant women each year. And in looking at their data, there's an important time point, which is 2004. So in 2004, recommendations for expanding pharmacologic prophylaxis were released from the Royal College. So we kind of want to look before that time period and after that time period. They had 3-year reporting periods at that point. So here's that data. So you can take a look. This data represents 24 years of maternal mortality from VTE in the UK. And I have it kind of divided up into two 12-year periods, from 94 to 2005, and then from 2006 to 2017. And you can compare before and after the protocol with the expanded heparin prophylaxis. And if you compare these two time periods, there's approximately a 40% decrease after compared to before the release of the protocol. So this is pretty good. I mean, this demonstrates progress, I think, in the UK for maternal mortality from VTE. And one thing people worry about is you're using all this heparin. Could there be more hemorrhage? Could there be risk from hemorrhage? I know there's a new study out that says maybe yes. But if you look at the data in the UK, over the same time period, no increase in maternal mortality from hemorrhage. So when we look at these numbers and we say compare them to the numbers in the US, where we don't use a lot of heparin, the mortality from hemorrhage in the UK is about a third what it is in the US. And as you can see with this figure, pretty stable over time. Okay, so I find the data from the UK compelling. I think one question you always ask in the situation where you're looking at an outcome over time is, could there be other trends that are accounting for this differential? It's unlikely that the differential is due to other trends. Risk factors for VTE in the UK are increasing. The cesarean rate went from 20% in 2000 to 26% in 2015. There's increasing overweight and obesity in the UK. About half of pregnant women were overweight or obese at their first prenatal appointment in 2016 to 2017. The data is over a relatively long study period, and there's a sufficient number of cases where it's unlikely statistically that this is due to type 1 error. And one thing about the data is that towards the end of the study period, there's an increase in first trimester deaths that couldn't have been prevented with heparin. So if anything, there's evidence that the current data is biased towards underestimating the benefits of heparin. Okay, so that's the data from the UK. We'll shift to the US. There's a study from the Hospital Corporation of America, which is a large chain of hospitals in the US that's very influential in our clinical practice. It was a pre-post study where HCA, the intervention was to use pneumatic compression devices for cesarean delivery. So before their intervention, they had about 7 deaths from PE in 460,000 cesarean births. Then after they started using the compression devices, the SCDs, there was 1 death in the same number of cesarean births from PE. And this was statistically significant. And this is the study that really kind of guides clinical management in the US. Okay, so this is the evidence that we have. What is that translated into in terms of epidemiology in the US? So this slide demonstrates proportionate causes of maternal death in the US from the late 1980s to the early 2010s. And you can see the area that's circled, it's death from thrombotic pulmonary embolism. And if you look from the late 80s to the early 2010s, VTE accounted for a decreasing proportion of maternal death, going from about 12% to 9%. That sounds kind of good, but unfortunately, if you look at the absolute risk of maternal death over that time period, the absolute risk of maternal death has approximately doubled. So if you look at the absolute risk of maternal death from VTE, it's likely either the same or potentially even higher. So, when you look at this data, I think it's pretty clear that in the US, we haven't made progress on VTE, maternal mortality from VTE, the same way that the people in the UK have. And so why might that be? Well, I think this data from our CDC is helpful. The investigators at the CDC looked at VTE risk during cesarean deliveries over an 11-year period, 2004 to 2014. The top line is the gray line is all VTE events. And what you see is a decrease in risk from approximately about 12 per 10,000 to about 8 per 10,000. So that sounds good. But then what they did was they went ahead and they disaggregated the VTE into deep vein thrombosis, DVT, and pulmonary embolism, PE. And what you see is that the risk reduction, probably with our SCDs, probably with the boots, really reduced DVT by about 40%. And that's good, but it really didn't do much in terms of pulmonary embolism, which was consistent over the study period. So, maybe with our strategy, we reduced DVT, but maybe we're not doing much in terms of PE. And I think, a reason for that might be the prophylaxis, but I think also on a population basis in the US, many risk factors for VTE are common and increasing. So In the US, cesarean delivery is common. About a third of patients deliver by cesarean. Obesity is increasing, infections increasing, hemorrhage and transfusion are increasing, preeclampsia is increasing, and preterm birth is common. So we did a study which will be published probably in the next month or 2 months in the Green Journal, where we looked at trends and risk factors during delivery hospitalizations for VTE. So we looked at vaginal delivery and cesarean delivery separately. We looked from 2000 to 2018, so a 19-year study period. And so we can look at cesarean delivery starting in 2000. The risk for having some other VTE risk factor, obesity, infection, preeclampsia, about 27% of patients had at least one risk factor who had a cesarean in 2000. By 2018, it's almost 45%. So pretty big change, 27% to about 43%. For vaginal delivery, also a big increase, 18% to about 32%. So these are changes in the risk profile. Risk continues to go up for VTE. We also updated the CDC's analysis for the last few years, and we found that both for vaginal deliveries and for cesarean deliveries, since 2014, risk for pulmonary embolism is appearing to increase. And this is, again, national data that hopefully will be published soon. So that kind of leads us to the primary clinical debate, which I think is really, should we be using heparin versus mechanical VTE prophylaxis after cesarean and then during antepartum hospitalizations? There are some pros of mechanical prophylaxis. The data is supported by that HCA study I mentioned. It's relatively low cost. There's no risk of bleeding. There are some drawbacks. Patients often don't use the devices appropriately. There's lack of clear indications for duration of use and discontinuation. Operational factors are a problem. Sometimes the devices don't work. They're not plugged in. And interventions to get patients to use the devices better generally have not been effective. And finally, there's no comparative effectiveness data. There's no evidence that maternal mortality from VTE has decreased in the US with these mechanical devices. Pros of heparin prophylaxis, I think it's supported by data from the UK. It's very easy to operationalize. You just give the patient the shot, and then you don't have to worry about whether they're using it correctly. And there are minimal issues related to compliance. Con heparin prophylaxis, getting a patient anesthesia, epidural or spinal anesthesia may be more complicated for antepartum patients if they've received heparin. There's a small theoretical risk of bleeding, and there's no head-to-head data versus mechanical prophylaxis alone. Some critics have also cited cost as a concern. And then there's also the issue that in terms of efficacy, we're extrapolating data from surgical and medical patients. So there have been a bunch of guidelines that have been released. I talked about the Royal College. There's also the national partnership that I participated in. There are the ACOG guidelines, the CHEST guidelines. Hematologists have weighed in, SMFM. Kind of boiling it down, the Royal College and the national partnership broadly support heparin for hospitalized antepartum and post-cesarean patients. And then ACOG, SMFM, and the CHEST physicians support more narrow use of heparin. And so what does that translate into clinically? So this was a study that we did at our hospital. We looked at 300 patients who had a cesarean delivery. We looked at their VTE risk factors, and then we applied the guidelines to these patients to see how many of them would receive heparin prophylaxis. So for ACOG, using ACOG criteria, only 1% of patients would get heparin, and that was because they all had prior VTE events. If you use the CHEST guideline, about a third of patients would get heparin, and that was for having had an emergency cesarean, preeclampsia, obesity. If you use the RCOG, the Royal College guidelines, about 5 out of 6 of our patients who had a cesarean would get pharmacologic prophylaxis with heparin for cesarean, advanced maternal age, obesity, preeclampsia. So depending which guideline you choose, very, very different clinical management. So when our national partnership recommendations came out, many doctors in the US were very unhappy with the recommendations. Dr. Sabai and Rouse, who are prominent obstetricians in the US, they wrote an editorial. They said that they didn't like the recommendation for heparin being used so much. They were worried about the cost, they were worried about safety, and they were worried about efficacy. Another editorial came out a year later from Dr. McCombs, who's also a very prominent obstetrician. He didn't like heparin being used too much. He was concerned again about safety, efficacy, and cost. And so that's kind of where we are now, where I think some of us are enthusiastic for more heparin, and then others are more critical. So I'll just speak a minute about some knowledge gaps and maybe some research opportunities for how we could resolve some of the disagreements. I think there are definitely opportunities to reduce risk in the US from maternal VTE. One way would be to optimize mechanical prophylaxis. We haven't been successful with that, but maybe we can figure something out in the future. Another possibility would be to use the Royal College approach and give more patients heparin. In terms of improving mechanical prophylaxis, I think there are several questions that we could answer that could make the boots, the SCDs, better. One question that's directly related to the vignette that I started with is, when should these devices be discontinued after cesarean delivery? Do they need to be on for a couple days? I don't think we have good criteria for what constitutes a patient being fully ambulatory. And I think we have to figure out what can be done to improve device use in terms of operational factors, providing nurse factors, and patient compliance. For the orthopedic surgeons, when they have the patients using these devices, they want the patients to have these devices on 18 or 20 hours a day for them to be effective. And our patients have them on a small fraction of that time. And I think that we can do some research in terms of comparative efficacy. I think if we're using the SCDs, it would be helpful to know which patients do mechanical prophylaxis fail. Are there specific subgroups of women who may benefit from pharmacologic prophylaxis, who, even if they get the SCDs, they're still having these pulmonary embolism events? So could it be patients who undergo cesarean and are obese, or patients who undergo cesarean with other complicating factors? If we could identify some of those subgroups, that might be helpful. And I think that in the US, there might be opportunities for research. We have these large state perinatal collaboratives where they evaluate outcomes in a state or several states. So you have a lot of patients. You could potentially look to see where the SCDs are failing. And potentially, you could also perform some quasi-experimental models where maybe you're looking at different hospitals with different policies in terms of prophylaxis and using that as an exposure to analyze outcomes. And then finally, you need a lot of patients to be able to assess the effect of heparin prophylaxis, to be able to have meaningful comparisons. So maybe looking at electronic health record data is something that could be helpful. I'll just briefly say, some critics of broader heparin use have said you need to do randomized controlled trials. I just don't think that's feasible. If you look at the number of patients you would have to be able to have an analysis that looks at modest effects for these rare outcomes, it might be hundreds of thousands of patients, and it would be extraordinarily expensive. And when they've tried pilot studies, it hasn't worked out well. So I don't think RCTs are the answer. So I'll conclude, my take from the epidemiology is that, when you look at the UK, they've seen a 40% decrease in mortality from VTE, and the data is good quality. Chart reviews, clinical information, it's really gone down in the setting of rising risk. In the US, maternal VTE mortality has not decreased. I think you can say it's either stayed the same or increased slightly. Our data, it's not as good as the UK data, it's administrative data. But it doesn't seem like we've made the same improvement that people in the UK have made. And in terms of strategies in the US, I think we have to do better. So we either have to improve the use of mechanical prophylaxis and broaden it, or I think we have to think about expanding pharmacologic prophylaxis along kind of what RCOG recommends and the national partnership recommends. So hopefully all that makes sense. Thank you very much.
Alice, thank you so much.